Let's dive right into this explainer and clear up some massive misconceptions about a really painful, draining bump right at the top of the buttocks. Whether you're a surgical resident, a general practitioner, or a patient desperately looking for answers, pilonidal sinus disease is incredibly misunderstood. So we're going to look at what modern science actually has to say about it.
Now, if you've ever dealt with this firsthand, chances are you've heard this classic line: you were born with a congenital cyst, and it grew a tail of hair. Well, I'm here to tell you that is absolutely 100% false. You are not born with this condition, and it's definitely not some congenital cyst that just magically sprouted hair.
The real paradigm shift here is that pilonidal sinus is actually an acquired mechanical condition. It's completely driven by gravity, friction, and shed hair. To put that into perspective, back in World War II, it was famously known as Jeep driver's disease because thousands of soldiers developed it just from continuously bouncing around on hard, vibrating vehicle seats. Here's how we're going to break it all down today. We'll start with myths versus modern science, move into the vacuum trap mechanics, the 4 stages of disease, minimally invasive treatments, definitive flap surgery, and wrap up with clinical takeaways.
Section 1. Myths versus modern science.
So, the absolutely crucial takeaway here is that this is not a skin problem, and it's definitely not a hygiene failure. International guidelines from major global surgical societies firmly establish this as a physics and mechanical issue. It's actually a chronic inflammatory disorder caused entirely by external forces acting on the specific anatomy of the natal cleft.
Section 2. The vacuum trap mechanics. It really boils down to a 3-step mechanical process. First, you have a deep, vulnerable cleft, which creates intense shearing forces every single time you walk or sit down. Second, infiltrating shed hair, which actually often falls from the head or the back, gets trapped in dilated pores. And finally, as that hair gets driven downward, your body reacts to it like a foreign invader. This creates a granuloma, leading to chronic abscesses and those painful tunnels under the skin. To really visualize how this works, imagine pushing a needle repeatedly through a piece of cloth in just one direction. The microscopic barbs on these hair shafts allow them to easily slide deep into tissue with every single step you take. But because of their shape, they literally can't slip back out. They are mechanically trapped in there.
Section 3. 4 stages of disease. Now, the physical presentation of the disease dictates the exact treatment. For stage 1 asymptomatic pits, we usually just observe. But if things progress to a stage 2 acute abscess with severe pain, the goal becomes an off-midline incision and drainage. Stage 3 chronic sinuses require obliterating the tract entirely, and finally, stage 4 complex disease means we need a complete flap reconstruction.
Section 4. Minimally invasive laser treatments.
When the disease is localized, massive open surgical wounds are thankfully no longer the standard. Today, daycare procedures like 80% liquid phenol provide excellent chemical ablation. Then you have EP-SIT, which uses a tiny scope for direct endoscopic retrieval of the hair. And incredibly, 360-degree radial lasers can actually close the tract from the inside out, with virtually no pain and 0 open wounds. Most patients are literally back to work in a day or 2.
Section 5. Definitive off-midline flap surgery. What happens when things are more complex? Well, leaving a massive hole to heal or closing it directly down the midline is highly discouraged these days. Why? Because it carries a staggeringly high recurrence rate and means months of painful packing. Instead, the gold standard is off-midline flap reconstruction. This approach flattens the deep cleft, completely removing those mechanical driving forces we talked about earlier.
Techniques like the Bascom cleft lift or the modified Limburg flap act almost like a giant puzzle piece. Surgeons transpose healthy, full-thickness skin across the defect. This completely moves the final surgical scar right out of that high-friction danger zone. You are literally changing the anatomical landscape to cure the disease.
Section 6. Clinical takeaways and guidelines.
These modern guidelines act as a protective shield for patients, and the rules are crystal clear. Never do radical excision during acute inflammation. Definitely embrace lasers for simple tracts. Use those off-midline flaps for complex cases. And absolutely avoid primary midline closures, because they just recreate that exact same vacuum trap all over again.
By following these guidelines and utilizing off-midline flaps for complex cases, recurrence rates actually plummet to under 3%. That is a massive victory for a disease that historically plagued patients with years of recurring, incredibly painful surgeries.
Alongside surgery, there's also a crucial preventative step: and that's targeted laser hair removal in the affected region. Think about it. If the hair isn't there to act as a barbed arrowhead, the mechanical cycle is stopped right in its tracks.
So, we've broken down the old myths and looked at the real mechanical science behind pilonidal sinus. Now that you know this is a hair-driven, physics-based disease, the big question is, how will you use this knowledge to permanently break the cycle of recurrence? Thank you so much for joining me on this explainer.